So what can be done now to tackle it? Well, the last year saw experts from many different fields coming together to pool resources in an effort to stop the NHS becoming overwhelmed by the scale of the coronavirus crisis. The use of digital technology to remotely monitor patients and the establishing of so-called virtual wards was one area that happened. So can the lessons learned now be applied to help reduce the backlog in other conditions? Let's go to Professor Gary Ford, who's a stroke consultant and chairs the Academic Health Science Networks, which was set up to encourage innovation in the NHS across England and which was instrumental in bringing together teams working on monitoring COVID-19 patients in their own homes. Also joining us, Dan Dat, who is founder of the technology company Humour, which provides the technology that enables clinicians to remotely monitor patients. Welcome, both of you. Thanks for joining us. Gary, first of all, tell us a bit more about how innovation and technology has helped to keep things going through the COVID crisis and how it may translate going forward.
Yeah, thank you. So the NHS is a really interesting position. The UK is world leading in research and innovation. Our universities and hospitals and healthcare system consistently produce advances in care, and that was shown during the pandemic. But for many years, we've lagged behind other healthcare systems in taking up new innovation and routinely providing it to patients. But what we've seen during the pandemic is the NHS can rapidly adopt new ways of working. So if we take the example you were just referring to, we needed a way to keep people with COVID well, both in the initial phase when they were diagnosed at home and then afterwards when they were discharged from hospital, to reduce the demands on the NHS and prevent hospitals being overwhelmed. So starting from scratch with nothing, these remote care pathways were set up. First one being COVID oximetry at home, where patients were given a small device to measure the oxygen in their blood, and then they're able to link through an app or by phone calls their information on how they were doing to a team that would monitor them. And then the virtual COVID ward model was introduced when people had been admitted to hospital or discharged, and that enabled them to be discharged earlier, and the team could monitor them at home again using a similar monitoring system. And this was taken up by essentially all commissioning groups across the NHS and hospitals, and had a massive impact on keeping people well who had COVID and ensuring our hospitals could still be able to treat everybody. And what we want to do is take that approach into going forward into the other problems the NHS faces.
Okay, so Dan, could you tell us a bit more about the technology then?
Sure, thanks, Joanna. The beauty of the kind of technologies that we implemented is almost like a sat nav that helps you to go from A to B. We are helping NHS Trust to prescribe an applications connected to devices, oxygen saturations device, one of those. And the applications tells patients what to do, when to do it, how to do it, while collecting essential data that historically you might have been able only to collect those data in the hospital settings, but now you can do at the comfort of your home. And on the other side, you have clinical teams looking at your data. The technology can flag the patients that they need the most attention. And suddenly, with the same number of resources in terms of number of clinical team members, you can look after twice more patients. And these are some of the stats that through our collaborations with NHSX around our projects nationally came out. And it's something so simple and scalable impacted, and we did a great work together with NHS to increase the capacity.
And just quickly on the statistics, because I saw that the data shows that for every 1,000 patients being monitored by that technology for surgery, 30 to 35 had their surgery date moved forward because it was deemed necessary because of what was being picked up by the monitoring.
That is correct. So this is the second application, which is now more and more relevant. The first one was how we can increase the hospital's capacity to look after COVID patients. For the case of surgeries and operations, as you know, we have about 5 million patients waiting for surgery. Now, the same application, it's being configured already for several NHS trusts with really good impact, and enables patients to look after while they're waiting for their surgery and flag the patients that their condition's deteriorating and by doing that, people can intervene. Some cases, we bring the surgery forward, and that avoids patients needing A&E visit and then emergency surgeries that, as you know, is very costly. And I think we have a great opportunity to scale that across the country together with all the technology partners, clinical partners, NHS help, and impact patients positively. Something that we did a great work, obviously, during the COVID timeframe. I feel a real sadness for families that we couldn't, bring the technologies during the COVID, but now we have an opportunity to double down so that we can touch and impact even more lives.
Gary, obviously it's clear to see the benefits of that technology when it's effectively additional monitoring that's able to be done from the home, which wouldn't otherwise be done, and it can identify patients who are at particular risk. But in terms of where you see the line being drawn in how much patients can be treated remotely with the use of technology and how important it is to still see them face to face, how would you define that? I mean, I mentioned that you're a stroke consultant. Do stroke patients just need to be seen face to face? Because, with any patient in any context, there are things that won't be picked up unless there is that direct interface.
I mean, clearly, if a patient has a significant stroke, they need to be in hospital and they need to be cared for on a stroke unit. But if we take the example of people who've had mini strokes, transient ischemic attacks, nearly all stroke services have moved overnight from seeing those people face to face to assessing them remotely by telephone or video consultation. And we've shown that that model is as effective, is often preferred by patients, and is more efficient. Now, we still need to bring people up sometimes to have tests such as brain imaging, but that has massively reduced the need to bring people to hospital. And then we're also seeing technology used in other parts of our pathway where we manage stroke patients. So, for example, we now have artificial intelligence to help interpret CT brain scans to look for a particular type of stroke where there's blockage of a large artery that needs treatment with a technique called thrombectomy. And often out of hours, there aren't the radiologists present in all hospitals to be able to do that expert reporting. So these artificial intelligence solutions can automatically help read that scan, support the clinician, and get those patients identified and rapidly transferred to centres to do the thrombectomy. And then at the other end of the stroke journey, when people are recovering, we've now got remote approaches to rehabilitation that are being used, and group lessons, etc. So I think we're just starting to really realise the potential to do more remotely, support people maintain their own health as well, and try and keep people well whilst they're on the waiting list if they're, for example, waiting for surgery.
Interesting to talk to you both. Thank you, Professor Gary Ford and Dan Vadat. Thank you.